Kia ora koutou nau mai, haere mai to tonight's Goodfellow webinar. I'm Katie McCulloch, a nurse practitioner working in Tamaki Makaurau, and tonight's Te Tiri Whakāro Sharing Knowledge series, which is created in collaboration with Te Whatu Ora, will focus on navigating radiology, referral to result. Our presenters tonight are Alexandra Viner and Dr James Entwisle, who will provide an overview of the new community radiology program and regional hubs, and Dr Danielle Gerrard, who will provide an overview on the National Community Radiology Referral Criteria, and then we will follow up with our standing segment of clinical updates with Dr Sue Tutty. So the first two speakers for the first presentation are Alexandra Viner. She's a program manager with extensive experience leading large-scale health service redesign across the UK, Australia and New Zealand, and her work focuses on multi-agency initiatives that aim to improve equity and health outcomes through system-wide transformation. James Entwisle was trained at St Mary's Hospital Medical School in London and qualified in 1990. He's based at Wellington Regional Hospital, and he's a radiologist with subspecialty interests in chest and cancer. He is a clinical advisor in the National Planning Funding Outcomes team with the present focus of rolling out greater and more consistent primary care community radiology. Danielle Gerrard will be following up the second segment and she is an Auckland-based GP fellow who is currently working as a HealthPathways clinical editor. She's actively involved in the community radiology space for the last 5 years. Thank you so much for joining us tonight. We'll hand over to you guys.
Kia ora koutou, ko Alex Takuingoa. Thank you for having me here this evening. I'm going to talk to the National Community Referred Radiology Program with my colleague Dr James Entwisle. I'll get right into it in the interests of time. So you should all be able to see the slide here, which gives a very succinct overview of the National CRR program. Listed here are the key program deliverables. These were approved by the Health New Zealand Board in March of 2024 and subsequently announced by the then Minister in June of 2024. The discussion today is going to focus on the national criteria, the development of community referred radiology hubs, and our digital interfacing that largely impacts the primary care referrers yourselves. So deliverables 1, 2 and 4, but in the interest of completion, I'll just briefly cover off deliverables 3 and 5 now. So the national contract, we are working towards a future state where community referred radiology sits under the existing hospital panel agreement to make an all of Health New Zealand outsourcing panel. So this will mean that contracts for community radiology that currently sit under third-party agreements are exited, and we're looking towards a national strategic approach to outsourcing with consistent standards, common pricing for both hospital and community referrals, and Health New Zealand visibility of referrals by having them all go through a Health New Zealand Radiology Information System or Health New Zealand RIS. And then deliverable 5 there, we've already done some work on improving access by removing co-payments where they exist. Around the Motu, these were largely in the central region, and that was done in December of last year. And we're also working with our SACS New Medicine colleagues to establish regional enhanced access hubs for those who need support attending radiology appointments, and that's well underway as well. So with these core deliverables, the intent is to deliver really 4 key program objectives, the major one being improving equity of access to care. So for your patients, similar wait times, procedures and follow-up for similar presentations across the country. Improving patient safety, and a lot of that is through our digital interfacing work, closed loop referrals to report sign-off, avoiding unnecessary visits to hospital for patients having to present to emergency department or attend FSAs, first seen appointments, to go on to get a diagnostic image. And lastly, as briefly mentioned, reducing barriers to attendance. So moving on very briefly, and Danielle's going to talk much more about this, but national criteria have been developed. James will talk a bit about how they were developed. These have been aligned across health pathways and primary care radiology referral platforms. A key date being today, with ultrasound and CT access going live, which has followed X-ray criteria going live across health pathways at the beginning of the month. One of the first substantive pieces of work that the national team have done is looked across the radiology referral platforms that exist across the country and updated them to align with the criteria, the national criteria. So from a referrer perspective, the referral platforms stay the same, they should look the same, and relevant content has just been changed. You'll see here that for some of the platforms working with the vendors, a minimal viable product approach has been taken. For example, BPAC and Te Manawataki have an intent to progress with more detailed form changes over the coming months, but for the purposes of meeting the September go-live dates, they've noted the change and linked through to the health pathway sites for relevant exams. With other clinical forms, such as the HealthLink form, taking additional modalities and body part options and aligning across where they're already used in the country. So HealthLinks, Auckland, Hawke's Bay and Northland. Now, I'm not going to go through our digital work in detail, but I thought it was worth giving an overview of the interfacing work in its entirety, as the referral form changes are part of EPIC 1 and a significant digital interfacing program of work that's to be delivered within this financial year. And many or all of the components of this work are really designed to support clinical decision making and patient safety. I'll hand over to you, James.
Yeah, so we're in phase 1 at the moment, and that's the delivery really of main 3 modalities of X-ray, ultrasound, and CT, and both for adult and children. In terms of referral access, there's been a focus on general practitioners, urgent care doctors, and nurse practitioners, and there's also increased access to new tests, and particularly we put a focus on suspected malignancy. So the CT chest, abdomen, pelvis is a relatively well used test in the hospitals, but historically primary care hasn't been able to request this for patients with weight loss, significant symptoms and signs of malignancy. So this was actually piloted in Mid Central in Palmerston North and shown to be highly effective with a good pickup rate. And the criteria really are an extension of that. So phase 1 now, where the CT and ultrasound criteria go live tomorrow, really. We then move into phase 2, and we're doing work on this already. The initial things really is to look at DEXA as part of the osteoporosis pathway, and breast imaging for the different components of breast imaging, symptomatic breast, as well as high-risk screening and surveillance. Although we're just coming to terms with public health about who covers what on this. We're also looking at eligibility of other health practitioners. So we're getting requests from all parts of the health system to the pots of money and to the imaging, and I've done some initial work on this. I'm working with the Radiology Network. Frequently asked question is maternity ultrasound covered? Unfortunately, it's not in this program. We've been working with the maternity team, and I think there is the opportunity if there was future investment for this to be incorporated, but there is some logistics of that. ACC is not covered part of this, We're working with the National Screening Unit on the interface between community referred radiology and screening and surveillance. There's been quite a robust process of how these criteria have been developed. Big shout out to Kate Aiken, who's done the main holding the pen on this, working with a team. So Kate's done a evidence-based trial of the literature. She used the 2014 criteria, which have now been updated, looking at health pathways, number of literature sources, including iRefer, which is used in the UK by the Royal College of Radiologists, NICE guidelines, ACR guidelines. There's a primary care GP advisory group who worked with Kate in developing the criteria. And there's also subject matter experts that were pulled in for different criteria and sub-criteria. And as part of a radiology group, which is also involved. This has gone for extensive consultation and has been endorsed both by the National Radiology Clinical Network and the highest governance group in Health New Zealand, Clinical Governance Group in Health New Zealand, the National Clinical Governance Group. We'll talk a little bit about the pathways, and Danielle will talk about that. But we are finding some minor inconsistencies with the criteria, which we will iron out in future drafts. One thing that we're really, really passionate about is making sure that primary care is involved. As I say, the primary care have been involved in the development of the criteria. We've had regular sessions with GPNZ and the PHO leader group, the national forums, and also national digital work as involved primary care. And we'll talk a little bit about the regional radiology delivery, and it's important that primary care are part of the leadership teams and governance for community referred radiology in the regions.
And another key deliverable of this work was developing regional CRR hubs. And another significant piece of work was commissioned, and Dr. Danielle Gerrard, who's speaking next, held the pen on that work, with the output being a national design document that set out core requirements of regional hubs following an extensive consultation process. The four core functions that are presented here, the prospective triage and advice and liaison function. We've got proven results already in parts of the country that have CRR hubs, so we took learning from these areas, and in addition to that, are looking at retrospective audit for acute demand and for new tests that Danielle will talk through, as well as education, both to primary care on their new national criteria and ensuring primary care referrals are accepted by radiology departments and providers. So a two-way liaison and advice function there. At the moment, the minimally viable hubs have been stood up across the country. We've got GP radiology liaison regional leads appointed in 3 of the 4 regions, change management FTE, and they will be supported by primary care radiology liaisons who will undertake the majority of these hub activities, and they'll be set up over the next 6 to 8 months. In addition to that, we have a national hub network that's formative, which will look at change control processes for the national criteria, working with HealthPathways, national clinical audit using a consistent tool, and education programs based on audit findings.
There's 2 major radiology initiatives under the way. So we're delivering our community referred radiology, but there's an announcement last week of a broader diagnostic program, which I'll go into a bit more detail. And as part of that, there's aimed to be an uplift in capacity, and that can be HSS, the Public Health New Zealand capacity, but also the use of private, and that approach really will depend on districts and regions. The hubs are expected to be fully operational over the next year, and will move much more to a regional service delivery model. So I think historically radiology has been delivered locally, and that you see the variation between the different districts across the country. We'll move towards regional services. And I think the greater availability of information in terms of data of radiology, but also a greater visibility of the wait list. And I'll answer out some of the questions in the chat about the variation of wait lists later on in the questions. We're also working with hospital referrers, and have sent details out to them of the community referred radiology about the scheme, about how they should and shouldn't use it. So they are able to recommend to primary care if asked for advice, if it can avoid first specialist appointments, acute referrals for primary care to image, but they shouldn't try to effectively offlift to take the patient from their waiting list and put it on the primary care waiting list. And so that's an important, we're working to make sure that this is really delivered for primary care and not for the hospital specialists. You may have seen the minister's announcement last week of a $65 million investment in the diagnostics program. This is largely radiology, but does include colonoscopy, echocardiography, and the aim the radiology network has been looking forward to this investment announcement for a while. So it's great to see, and the idea there will be an uplift in capacity, but at the same time there will also be a focus on making sure that we use our limited capacity well. So there's a whole focus on reducing low value imaging as well. So that's an important part. So, and it clearly aligns with four of the five health targets that we're seeing. That diagnostics plays an important contribution. So there's additional money as part of the diagnostics program, as well as the ongoing 30 million as part of the community referred radiology.
Cognizant of time, very quickly on future state. We've talked about phase 2, which is also to be delivered in this financial year, looking at other modalities and eligibility of other professionals. The future state, and working with our diagnostic program colleagues, as well as what the digital interfacing has been premised on, is working towards consolidated wait lists. So the premise being that patients are seen on clinical need, irrespective of whether it's a community referrer or a hospital referrer. And we're working with regions on readiness to move towards consolidated wait lists on Health New Zealand RIS, as well as consideration of over time moving towards smart triage and the formation of national networks to maintain alignment and connect regions. We're not shy of feedback. James spoke briefly on feedback on the national criteria, and I mentioned the role of the national GPRL network to develop a consistent process for updating the criteria based on changes to the clinical evidence base. In the interim, there is a feedback tab on the Care Pathways site to provide feedback on the criteria back to the team.
Tēnā koutou katoa. My name is Danielle Gerrard. So I'm a specialist GP. I'm one of the Auckland-based clinical editors with the National Health Pathways team. I'm the lead clinical editor for the new community radiology pages. However, getting the new criteria up online has definitely been a team effort. And I just want to acknowledge Mary McLeod, who's one of our Health Pathways coordinators in Canterbury, and who has been instrumental in getting us this far, as well as Justine Lancaster, our national clinical lead, and Chris Scott, our national manager. And these pages have also had significant input from a large number of our clinical editors and coordinators from around the country. And I just want to acknowledge that we wouldn't have been able to get them live online without the full Health Pathways team. So what I'd like to do tonight is to provide you all with an overview of the community radiology pages so that when you're using them, you'll all know how to find the specific information that you need at the time, especially as we continue to work to get the criteria up online. So we're going to work through the radiology pages, some of the criteria, but not the detailed criteria in full. We've got a total of 30 community radiology pages, which include all the ones you can hopefully see on the screen. These are what we call lead region pages. So we develop a single page and then adapt it for each region. And this ensures consistency, not just in the content, but also how the page appears to you when you're using the different radiology pages. And it also makes it easier to find the information that you need, especially if you work in areas that straddle the borders of different health pathway regions. So while we have been working on getting the new criteria up online for many months, it's been quite a complex task, rewriting the new national community radiology criteria to fit our health pathways format and make sure that the new radiology pages have all the information that's relevant and are easy to use. And the other complexity has been that each of the radiology pages has a number of associated condition pathways which also need updating. And while some imaging types only have a few associated pathways, others are more complex, such as our CT head, and you can see the list there for that, and our imaging pages, our renal imaging pathways, which you can see as well. There are actually a total of 206 associated pathways that need updates on each of our 9 health pathways sites. So around about 1,850-ish pathways that also need to be updated across the country. And then there's another few hundred radiology pages that need to be inactivated because they're being replaced by the new radiology pages. So you can just understand what a complete mammoth task this is. And we do ask for your understanding as we get them up online over the next few months. In the interim, there's a few things to be aware of. The first are our CE notes, which have already been added to your local radiology pages and are also now being added to some of the local associated pathways, which are impacted by the new criteria. And as you can see, these CE notes direct you to the Community Radiology Access and Funding page, which is where you'll find some mini PDFs of the new radiology criteria, which we'll talk about shortly. But I thought we'd just quickly have a look at the 3 new radiology pages, which are already live across everybody's regions. And these are the Community Radiology Access and Funding page, Radiology Advice, and Radiation and Medical Imaging. There are links to the first 2 pages at the top of all of the radiology pages as a see also, and the X-ray and CT pages have links to the radiation and medical imaging page. So the Community Radiology Access and Funding page has 3 parts to it. The first is a general overview of the 4 different types of radiology services which are available to community-based referrers throughout New Zealand. These include publicly funded imaging, including the Community Referred Radiology or CRR services, ACC funded local private radiology services, and then maternity imaging is publicly funded but a separate section of its own. The second section contains background information about the new National Community Radiology criteria, and I've put a brief summary on the slide. But the key things to be aware of are that these are consistent across the country and enable imaging that will alter management and improve outcomes for the patients, and that the current criteria are just the first tranche and new imaging types will be added over time. This page also documents the prioritization timeframes, which may be of interest to you. And these are the timeframes in which the imaging should be performed for each specific criteria. And as I think Alex or James just mentioned, these are the same as the hospital radiology referrals, ensuring that all patients with the same condition or need for imaging will get the imaging prioritized to be done within the same timeframe, irrespective of who has referred them. So most importantly is the third part of the page, which is this collection of mini PDF links right at the bottom. So Mary's taken the 107-page National Community Radiology Criteria PDF, and she's split it up so that there is one for each of the new imaging types. And this is going to be the easiest way for all of you to find the new Community Radiology Criteria while we're getting the radiology pages up and live. For example, if you click on the Abdo X-ray link, it'll open that little mini PDF, which you can see the image of, which will have both the adult and the PEDS Abdo X-ray criteria in it. Once your region has taken the Abdo X-ray page live, the mini PDF will be replaced by a link to your local Abdo X-ray page. But for now, we strongly recommend coming to the Community Radiology Access and Funding page when you want to check what the accepted criteria are prior to referring a patient for imaging. And just to note as well, that once all the updates have been made to the associated pathways, the pathways will either list criteria, for example, in a Dropbox, or link away to the appropriate radiology pages, just like our existing pathways do. So the radiology advice page is where you're going to find all the relevant contact information for your local community radiology hub and your other publicly district funded radiology services. Some regions, such as you can see our Auckland one here, will also have a section with information for local private radiology providers. The hub section currently has some basic information about what the hubs are, and as these are stood up, each region will update the section with information such as who the hub team members are, what they do, and how you can contact them. The last of the 3 pages provides information about the risks of ionizing radiation for health professionals to consider when requesting imaging and also to discuss with patients if needed. And there's some useful resources at the bottom, both for ourselves and for patients if anyone wants to read about them in more detail. But the bread and butter of the radiology pages are the request pages. These are the ones that document the radiology criteria and provide information on how to refer for each of your regions. There are a total of 26 community radiology pages, which includes all of the ones that you should be able to see on the screen. And we've split them into pages that made sense clinically. So most of them relate to a specific scan type, and then will include both the adult and the child criteria for that imaging type. But there were a couple where it made more sense to split them based on the type of patient presentation, and that's the shoulder imaging in adults and the hip imaging in children. Not all of the pages have national criteria. For example, you can see we have an MRI page, which still only has local criteria, which for many regions will be that we cannot directly request publicly funded MRI imaging. But we just wanted to make sure that the MRI page was also future-proofed, as the next tranche may contain some MR imaging that we can access. And it's also where you'll be able to find your local ACC, GP, MRI criteria, referral processes, and information. So for each of the radiology request pages, we've formatted them in the same way. There are 3 sections, public at the top, then ACC, and private at the bottom. The content for the public section will change depending on the imaging type and local referral processes, but the ACC and private sections are relatively consistent. We're going to have a closer look at the public radiology section, as this is where the community radiology criteria live. So as you can hopefully see, there are 4 parts to this section. What you need to consider before you refer, including the referral criteria, what information you need to include or provide with your referral, how to send the request for that specific type of imaging, and what information you need to provide or should provide to the patient. So the referral criteria sit within the first section and will usually include both adult and child criteria, with the exception of that shoulder imaging in adults, hip imaging in kids, and our MSK X-ray pages, which we split into separate adult and child pages. The National Community Radiology criteria break the criteria into 4 sections, which you can see on the screen, and we've also used these within the radiology pages. The critical section tells you when the patient needs acute admission or at least a discussion with the relevant specialty. The accepted section lists the accepted criteria, and the format for this will change a little depending on the imaging type, and we'll have a look at some different options in a minute. The alternative management may either redirect you away to seek advice or to follow another pathway to manage the patient clinically, or may suggest an alternative type of imaging which is more appropriate. While the not publicly funded section includes clinical scenarios where imaging may be appropriate, but which are not publicly funded because they're not going to alter management for the patient or change their clinical outcome. And it's important to be aware that not every condition has criteria under each 4 of these headings. For some of them, they may only have advice to refer acutely or alternative management advice. So the accepted criteria are generally listed in order of priority, with the acute within 24 to 48 hour criteria listed first, followed by any urgent within 2 weeks criteria, then routine, and then those that are done at a specific date in the future. If there is no time frame listed by that criteria, then you can assume it is a routine referral. Your local pathways will also have guidance on how to refer. And you can see, hopefully, for this Auckland Abdo X-ray criteria at the top, we've advised that it should be requested by a POAC within 48 hours, because in this case, it will prevent the patient from needing an admission. Down at the bottom, you can see the abdo x-ray recommended by a secondary care clinician, PCRL, for any of the following timeframes. And this is what I call a phone a friend option. We all know that there's likely to be times when imaging is needed, but the patient doesn't meet a specific criteria or where it's not clear how to manage the patient. And when you call them, the secondary team may recommend imaging and or other investigations. And because of this, every imaging type has got a phone a friend referral criteria option. However, the timeframes do vary depending on what is appropriate for that imaging type. So it's important to always check. And there are two key things or really important things to remember with this option. If you've discussed a referral with someone who's recommended imaging, it's really important to include the name and role of that person when you're referring, or it may be declined. And if it was recommended in a radiology report, also state this and include when the follow-up imaging should be done. So I also just wanted to show that for some imaging types, such as our pelvic ultrasound page here, where there are a large number of conditions, each of which have different timeframes, we've listed the criteria alphabetically, often in drop boxes to make it easier to find them. Within each of the condition drop boxes, however, the criteria will still be listed under the headings each of those headings that apply. For example, in the AUB box here, we can see we've got accepted and not publicly funded criteria. Whereas for the cervical polyps, there's only alternative management advice, as there are no accepted referral criteria. And I just thought I'd quickly mention a few of the imaging types that are useful to be aware of. So the first are the collective renal imaging pages, as these often overlap in terms of why you might request them, and also because some of them are new for some of the regions. So you can see we've got renal ultrasound, CT KUB, CT IVU, multiphase renal, and KUB x-rays, which is a type of abdo x-ray, which is the page that you'll find it on. An example of how these overlap is at the bottom there. So this has been taken from the CTKUB page, but you can see that it's actually recommending renal ultrasound for patients presenting with renal colic who are pregnant or who are female and aged younger than 35 years to avoid irradiating them. CT, IVU, and multiphase renal CT are likely to be new imaging types for most of you. So these are CT scans where a series of images are taken at different phases, usually with a non-contrast arterial phase and portal venous phase imaging. And so for CT IVU, this tends to look at the renal tract, including ureters and bladder, whereas the multiphase renal focuses more on renal lesions. And these will often be recommended by other imaging, such as a renal ultrasound, where you see an indeterminate renal lesion that needs further investigation. CT Other is also a little unique in that this is a catch-all for all CT scan types that are infrequently used. So these will always require endorsement by a secondary care specialist, as you can see on the screen, or the community radiology hub teams, or may also be recommended by a radiologist in a report. And the most common type of scans that we would expect to get through this would be a CT abdo-pelvis, or maybe a CT carotid angio. But any CT type that doesn't have its own specific community criteria can fall under this one. CT chest abdo-pelvis is another imaging type, new for most of the country, and this is the kind of criteria where you know the patient's got some significant but non-specific symptoms. You think they may have cancer. You can't figure out which part of the body, might be considering a lymphoma, need to check both the chest and the abdomen to exclude malignancy. It does have very well-defined criteria that the patient needs to meet, but also has that phone a friend option for a patient who still falls into the grey, needs a discussion, and imaging may be appropriate. CT chest, I just thought I would mention, firstly, because it's important to understand that chest x-ray and CT chest are closely related, and that all patients getting a CT chest will almost always need to have had a chest x-ray first. And this is partly because chest x-ray is a quick and easy way to get a look at what's going on in the chest, and most regions should also be able to get a same or next day chest x-ray. And while there is a lung cancer related criteria at the top there, which does not require endorsement, all of the other criteria do need to be recommended by a secondary care specialist, hub team member, or radiologist. And the CT chest pathway is also a little unique because it contains some background information around how the criteria were developed. And this is one example of where the criteria has had to balance the needs of all patients to access imaging against CT capacity across the country. Ultrasound guided FNA is the last that I thought I would specifically mention. And as you can see, the criteria do require endorsement. But this might be useful, for example, if a thyroid ultrasound report recommends an ultrasound guided FNA of a thyroid nodule, then you can refer directly based off that. So just very briefly going to mention the next 3 sections, but I do highly recommend having a look at the pages when or the first time that you're on or the next time that you're on. In terms of preparing or what information you need to provide, it might seem pretty straightforward. However, it's really important that you take into account or consider the additional information, such as which arm or leg needs imaging. Can the patient get onto the ultrasound table? Do they need an interpreter? Will they fit within the CT or the MRI tunnel? Because having this information provided in the referral makes a big difference in terms of ensuring the patient gets their scans done in the right location and at the right time. The sender request section is where you'll find the information on how to refer. This will vary by region, but at present, you can expect these processes to be the same as your current referral processes. And if any change in the future, a clinical edit note or CE note will be added to the page as a heads up. So the final point is just to always think and make sure that the patient's aware of why they're being referred and what for. So as mentioned, all regions have our first 3 pages live on your local Health Pathways site, and we're all currently working on Abdo X-ray and the chest sweep that you can see up there. The order for the rest of the rollout's a little bit fluid, so I can't give you a definitive list of what will be rolled out and when. But we are prioritizing on a number of different factors, such as imaging types, which are new for the regions, whether a new associated condition, lead region pathways about to be released, such as rhinosinusitis, where we've got existing lead region pathways such as cognitive impairment, headaches in adults, which we can push out CT head criteria quickly with, and where we've got the TIA and stroke pathways coming out soon. And then the other criteria for prioritization is where radiology is key to the management of the condition, for example, DVT ultrasound. But key takeaway message for today, after all my talking at you all, is that the collection of mini PDFs at the bottom of the Community Referred Radiology Access and Funding page are going to be your best friend over the next month or two or so as we get everything up online. This is where you'll find the new community radiology criteria. And just a final reminder that you'll know when your region has that new radiology page live because the PDF will be replaced with a link to that page. And that's me.
Kia ora. Thank you so much for your presentations tonight. So we're going to move on to the Q&A, and we have Tim Wood, who is the Group Manager of Planned and Unplanned Care for Te Whatu Ora, joining us and supporting the panel. So we've got, as James alluded to it, we do have a couple of questions around wait times. So in terms of, and I think you both mentioned that there would be similar wait times to what we already expect from radiology referrals, but what's that going to look like transferring into what it actually looks like for our patients getting their requesting?
There's considerable variation across the country in terms of wait times. Generally in public, it's not as good as private, and then we have different community referred radiology schemes, some which go straight to private and some which where it's completely public. So there's a big focus on improving capacity in public and growing the workforce for public, better machines as well. But that's clearly a relatively slow business. So there will also be the use of the private sector, but the use of the private sector will be required, but will aim to be more strategic. So that we're just working out what the balances are. And I think what does strategic use of the private sector look like is a question we're working through at the moment. It may be quite different for rural patients if they've got a private provider locally, and which is very different to Auckland Metro, where there are lots of private providers. So the network and the diagnostic boost program is working through that. But there is a considerable investment in radiology, hopefully, which will translate to better patient access. So tens of millions of dollars. So that's it. That's a good thing.
Someone's just asking, is there any capacity to take into account accessibility of different modalities for rural patients? For example, rural patient 2 hours from a CT scanner with a suspected renal colic, but an X-ray is available 5 minutes away. Can someone have to speak to that in terms of meeting the criteria?
The criteria have some wriggle room about it, and particularly the renal column. We realised that not everyone's close to a CT. So clearly, most people we would use CT, but realise sometimes we have to use a combination of ultrasound and plain film. And if the criteria aren't right for rural patients, and there is that deviation, you may have a local pathway which describes that. Or we will update the criteria. The pathways and the criteria need to work closely together and align.
Someone's commented here that they're from the Manawatu and the CTTAP pathway is brilliant. However, they struggle to get an ultrasound pelvis funded. Can you also clarify if a community services card is needed for publicly funded imaging?
So the requirements for who gets publicly funded imaging are actually on the radiology pages at the very top in that first line, in that first section, in the public section. But there is no requirement as long as you meet the criteria for accessing free healthcare in New Zealand, then there is no extra cards, no extra payments, no extra anything required within the public system.
In terms of the funding, so it's 30 million per annum. Is that correct? And then what happens if all that money goes? Will the referral stop? Will we have to go? What's the fallback?
So it's sustainable funding. So it's renewed 30 million each year into the program, and part of the reason we are phasing rollout is to allow for a monitoring period to assess what the impact of the new criteria is, and also have better visibility of what is actually demand versus a transfer in demand from hospital to community. So to look at that net increase, and that will drive future access decisions, as well as looking at this panel pricing and national contracts where we would have better negotiation over the outsourcing. So a period of monitoring, and I think just a nod to all the components, all the deliverables in the program working together to be able to look at best for system, best for patient with the funding we've got.
In terms of ongoing, I guess in terms of patients currently that are waiting for referrals, that are potentially waiting for a long time, I know that I have a large number of patients I referred for a pelvis ultrasound back in March that I'm like, when am I going to see? These people that we referred all that way back ago, what will that now make those referrals urgent? What happens to those referrals that we've already made?
Well, we have given instruction to the regions that those patients already on a wait list stay on the wait list.
There are two bits to the question. So I don't think patients will be removed from a wait list if there's a change in criteria. But I think your point is that your patient may be deemed urgent where historically they've been deemed routine. So as part of the other initiative, there will be a revalidation of wait lists, which if you're a radiology department like mine and you have a large waiting list, it's a painful process of going through the wait list, making sure patients haven't had imaging done already, or that's still valid. But it will include reprioritizing patients who, if they've been if they reach the criteria now, to become a higher priority. Hopefully that makes sense.
Yeah. Okay, brilliant. Thanks, James. Will the referrals be audited to identify any inappropriate referrals, or will the providers be audited for their responsiveness of the service? Currently people are waiting sort of large lengths of time. Is there going to be any review of time lengths for accessing?
As part of the diagnostic program, there will be monitoring basically of the wait list and access. So I think my understanding is the access will be largely on CT and MR in terms of national. But part of our program is that we'll be monitoring the community aspects of it. And across modalities and across the districts, but also particularly with some of the new imaging that we put in, the real focus on that to see if it's working, whether people are using it appropriately. I think, and then there's at the same time we're also really concentrating on some of the lower value imaging, where we're probably over imaging at the moment, with a review to try and free up our workforce and machine capacity.
And
Okay.
while I'm not technically here in the capacity of the hubs, but the hubs themselves have clinical auditing and evaluation built into their system. So that should be happening as part of the hub activities across each of the 4 regions once they're in place.
Brilliant. Thank you so much. You mentioned that hospital specialists can't override and jump onto the CRR. Someone's just asked you about ED clinicians referring patients directly to have urgent ultrasound for a DBT in the community instead of going through their primary health providers. Is that acceptable, or would that come under that hospital?
For example, in Auckland, where we have the POAC system, where the ED can use primary options of acute care to get DVT ultrasound themselves in the community, so that they can discharge the patient back out from ED. So that's that question. So the question would be, are they falling under community radiology, or are they still separate hospital radiology?
That'll be detail that we'll work through in terms of the POAC program. So fundamentally, the principle is to move imaging from the POAC program, and it will be all in the community referred radiology program, so it's consistent across the country. But there are nuances we will need to work through in each of the regions around that.
Will the pages that have that include which of the private providers are available, will they also include what specific tests they can do and whether there's age limits and things and sedation?
So it will depend on what the regions have at the moment. I know we don't have that for Auckland, so that'll be something that I can think about. And I will suggest it to the other regions as well, that if we can include that detail, because I know that will save time for people when they're looking at which patients to suggest which private providers for. So yes, great idea. Thank you.
And currently, referrers from primary care are sent to private providers. When and if will the hubs take over accepting referrals from primary care?
The hubs aren't accepting referrals instead of private. The change will be, as the national contract comes in, referrals will hit a Health New Zealand radiology information system, so they can be visible to the hubs. And those hubs will be expanded over time so that they can direct referrals to private or in-house, depending where capacity lies.
Can we start using the CRR from now on? And will it be directly free of charge for patients?
Yes and yes.
Brilliant. Thank you
With
so
it,
much.
the caveats about ACC
Perfect.
and maternity.
Yeah.
And just to clarify that, Katie, so there's been questions in the question and answer about ethnicity and that. So this is free to all clinically eligible patients, irrespective of ethnicity or whether they have a community services card or not. Just make that clear.
So for the referrals needing authorization by a radiology liaison, what do we do in the meantime while we're waiting for them to be appointed?
So all of the options, where there is that phone a friend option, you can also talk to a specialist, so the appropriate specialist. There was a question someone said, does that have to just be the SMO? Whoever you would normally call and get on the end of the phone when you call the Seek Advice or the acute phone, that person is entirely appropriate to be the person to endorse a scan. It doesn't need to be SMO or just a registrar. And so in the interim, the local specialists or radiologists, however you would normally get advice from them, or on radiology reports as they're coming out to you.
And can telehealth clinicians refer based on history for imaging, or are they still needing examination findings on the referral?
We've reached out to telehealth clinicians and made sure that they're interfaced with the relevant referral platforms. I think telehealth clinicians will use their discretion as to whether an examination is required, but are functionally able to refer.
Now we are moving on to our standing segments of clinical updates with Dr Sue Tutty. She is a GP liaison here in Tamaki Makaurau. Thank you so much, Sue.
Tonight, I've got a little bit less to talk to you about because our Pathways teams have been so busy doing all the radiology pieces, but there is a message from breast screening about the new changes that are starting with breast screening from the 1st of October, so from tomorrow, that is now being extended to women up to the age of 75. So all women who turn 70 after the 1st of October will be eligible for free screening every 2 years, and for women up to the age of 75. This excludes Nelson Marlborough because they have already started this. Basically, they were running the pilot, so they're already underway. And there is a new online system that will be used, Te Puna, and it's a bit like our cervical screening program, that's an opt-out rather than an opt-in. So everybody will be approached who fits the criteria and invited to have a screen rather than having to be opted in. They will, because it's got a gradual start and it won't be fully implemented till 2029, they're going to start with women who are 70 and who are 74. So particularly for the 74-year-olds, so that they don't miss out on the opportunity to get a last screen before they turn 75. Those who are 70 who have had a screen in the last year won't get a recall at this point. Only those who were screened the year before that, because it's every 2 years. And gradually that will cover all women between the age of 70 and 75. I wanted to talk a little bit about ferrous sulfate. Now, this is a supply issue because the company that has been producing Ferrograd will no longer be available in New Zealand, and stocks are likely to be gone very soon. In fact, I was asked to redo a prescription for someone last week. And so we need to move patients over onto the ferritabs instead, which is ferrous fumarate rather than ferrous sulfate. And just a note that ferrous fumarate does contain less elemental iron than the ferrous sulfate that we're probably more used to using. So it does need to be dosed twice or 3 times a day because you need 100 to 200 milligrams of elemental iron to build up to treat iron deficiency. 1 tablet a day may be sufficient to just maintain your iron stores, but not to build them up. Now, there's minimal difference in absorption between ferrous fumarate and ferrous sulfate, so that's not a problem. But just a reminder that the iron supplements that are available that are low dose are not suitable for treating iron deficiency anemia. And just wanted to talk a little bit more about iron tablets. And I think you will know that there's the AUB work that's also underway that is going to be launched very soon, that talking about abnormal uterine bleeding, and so iron deficiency is also part of that piece of work. So if you take your iron with vitamin C, so I've got a nice glass of orange juice there, it helps the absorption. And there are some products of iron tablets that have vitamin C included in them, but they aren't funded. It's a good idea to warn people about the side effects of iron tablets, the GI symptoms, nausea, vomiting, constipation, and particularly the dark stools, which may be concerning if you're not expecting it. So to remember, if people are getting a lot of GI upset, to perhaps start more slowly with your iron tablets, that it is okay to take it with food if it's causing upset. And again, the vitamin C rich food. So this page is taken straight out of Health Pathways. And to also remember that there are quite a number of products that will reduce the absorption of the iron, such as antacids and tannins. So it's good to make sure that you don't have those within an hour or two of taking your iron supplements. And also just that iron deficiency anemia is not really a diagnosis. It is it's something that needs further investigation, and it needs follow-up, that we should check that the hemoglobin concentration has come up over a period of few weeks, that it will take 3 months to replenish the iron stores once the hemoglobin has returned to normal. And in a study, this was a study that dietitians did, and they found that New Zealand women, 55% of them had serum ferritins of less than 30, which could be considered iron deficiency. And I just wanted to comment a little bit about serum ferritin, because I know that certainly in the northern region, and I think in most of New Zealand, a ferritin is of less than 20 is marked as being abnormal. Whereas we know that if you get a serum ferritin of 20, you've probably got virtually no iron stores. But anything below 100 is possible iron deficiency, or certainly that you are no longer iron replete. So that we need to really think about at what point we're intervening in people's ferritin. And certainly in pregnancy, it may be a very good idea to intervene earlier than we are, and perhaps avoid some of the more marked anemias that we see later in pregnancy, and some of the use of Ferinject, that if we had started iron sooner, that might not be necessary. And along with withdrawing the ferritabs, the ferridin, which is the liquid product of ferrous sulfate, is also being withdrawn. But there is a ferrous sulfate that's available in liquid form called ferroliquid. And this we expect that the stocks of ferridin to be gone by February next year. And this is ferroliquid. So it's pretty much the same product, but it will look different. It is MedSafe approved. You don't have to do a Section 29 or anything like that. It's fully approved. But that any different product might have slightly different side effects, so you need to warn people of this. Another thing that is put on Pathways at the moment is just an information piece about supporting medically dependent electricity consumers. And this is a new piece of work from the Electricity Authority that have mandated that they have an obligation to let all consumers know that if they have someone dependent on medically dependent on electricity, then they can get a form signed to say that they need access to power at all times. And just looking at the responsibilities that have been included in this document, so that the consumer needs to pay for the costs, but if the electricity company is querying it and want the person to be seen more than once a year to have this form filled out, they would cover the costs, but they may actually need it to be reconfirmed once a year. And that it is the role of primary care to identify the people who are medically dependent on electricity and to assist them in getting this. And this is a checklist that I found on their website, just further identifying our responsibilities, which seem quite considerable really in this piece of work, that it's our responsibility to assess what the need is and whether it would result in serious harm to the patient or death, and to ensure that the patient has filled the form out and in fact takes it back to the power company to have it processed, and that they have some sort of emergency planning in place in case of power outages. And the suggestion is at the bottom, having other equipment to use in case the power is lost to activate backup power sources or to relocate to a safe place. In terms of updates from Pharmac, these are mostly good news stories where supply is coming back. So ezetimibe with simvastatin was one that was missing, was not available in New Zealand for a little while, but they expect the resupply by next month. Soframycin is back in the country, but it just might take a little while for it to reach the pharmacies. For Asacol, mesosalazine, there is an alternative product available from the 1st of October, but it does need a Section 29 and further details on the supply of methylphenidate, which we've been talking about all year, I think. Ryzodec was something I wanted to mention because it has become a little bit of an issue. That it's, I mentioned it first in our May session, that it's a mixed insulin that's been available since the 1st of May, and it's a suitable replacement for Novamix 30, which will be discontinued next year. And it contains a long-acting insulin and a rapid-acting insulin. So it's a little bit different than the Novamix 30 because it's got this rapid-acting insulin as well, and Degludic, which is even longer lasting than Lantus. But the thing that's come to our attention is that Ryzodec must be used with a NovaPen 4. It doesn't come as a pre-filled pen injector, so you need to have the actual pen available. And apparently these can be sourced from pharmaceutical companies. So it's a good idea to have a supply in your practice if you are going to prescribe this new medication, and to make sure that patients know how to use it appropriately. And this is the example of the NovaPen 4, and there's instructions on HealthPathways on how to use this. And you see at the bottom there's a click box that you can go into that gives you very clear instructions on how to load the pen and make sure that the cartridge is working properly. So looking forward in our systems change section, abnormal uterine bleeding, you can see that we have a presentation on the 14th of October that I hope that you'll all come and join, which is another big piece of work that's being rolled out. 12-month prescriptions, I had hoped to say a bit more about that tonight, but I can just say that guidance is coming. And the shared digital health record is another piece of work that will expand the coverage of data so that when people seek care in places that are not their usual provider, that information will be available. And there's been work going on in the background on this with some focus groups with general practice and patient interviews. So they're trying to better understand how to support general practice and patients' needs better. Any questions?
Are you able to speak about the conversion dose from Novamix 30 to Ryzodec?
I think they recommend reducing the dose of Novamix 30 slightly because the rapid-acting insulin may work more quickly and you may get a low when you first start it.
Yeah. Is the liquid IRD subsidized?
For a liquid, yes.
For everyone watching tonight, thank you so much for joining us. Have a lovely night, everyone. Ka kite.